Thank you so much. Okay, here we go.
So Dr. Sindher, you should be able to, yeah, advance your slides.
Perfect. Hello, hello. And it's so nice to hear you're from New York as well.
Yes.
I grew up in Boston and was in New York and then Philly and then now have been in California for 8 years. Um, so
Thank you for
all
joining us.
righty. Yeah, I mean, outside of the fires, the weather has been phenomenal, but I do miss the East Coast. So yeah, I work with Sarah in our outpatient clinic. She helps me with our oral immunotherapy clinic and food allergy, and so today, really, she wanted me to kind of talk about just the treatment opportunities in food allergy. I feel like the past year there has been a lot of advancements and just trying to um, get a handle on what does that mean for our families and our patients. Um, okay, so essentially, as we all know, that the burden of food allergy has been continuing to rise globally. It's something that actually impacts every single continent, and more data is coming up showing that it's not just a U.S. problem or um, a, like a higher socioeconomic country problem. It really is a global problem. Um, and then in addition, risk of anaphylaxis, we understand, but there's also the cost, like outside of that risk of anaphylaxis is staggering. The food allergy costs in the US is estimated to be $24.8 billion per year, with an estimated cost of over $4,000 per child. And then there's really a lot of severe social and psychological burdens on the individuals and families. And not only do food allergic children or individuals really face dietary restrictions, but these restrictions often lead to exclusion from social events. There's concerns for bullying and anxiety. We've all come across families where they're afraid to go on a plane ride or attend a party or go to a large social gathering or let their child go to play dates because of these worries. And these are challenging burdens to deal with. And 89% of food allergic families have avoided doing just that, avoiding certain restaurants. 82% have changed their family traditions. 53% have skipped important school functions, and 45% have avoided airline travel. And then, we thought early dietary introduction is going to be a huge game changer. And several studies have shown that early dietary introduction and a diversity of diet has been successful in food allergy prevention. And there's several publications on that. And based on a lot of this data, we've seen an evolution of the guidelines that we share with our families. So, for instance, in before the LEAP study or the EAT study that came out, our guidance was delayed introduction, that you give peanut and tree nut later. You don't even start shellfish and fish till 3 years of age. But then the LEAP trial, which came out in 2015, was quintessential in changing that guidance because the study showed that peanut allergy was 5 times more likely in children who avoided peanuts. And then in 2016, the EAT study was published, which actually showed that children who remained in the study because they had a very high dropout rate and consumed the recommended amount of a variety of allergens had a significantly lower risk of food allergies. And based on that, we've seen kind of the guidelines change over time. And so to kind of go through a case in clinic and kind of tying in the different elements of food allergy, and I wanted to talk about Alex, who first presented to our clinic at 6 months of age. His older sister, 8 years old, Jenny, was also food allergic and had been going through oral immunotherapy through one of our trials. So family was already very much, their food allergic family. Older sister has food allergy. from the get-go, they were all about food allergy prevention. So up until that point, Alex was a healthy child. He had mild to moderate eczema that started pretty early, but appeared to be well controlled on topical steroids. And parents wanted to do early introduction and had started the journey of introducing solids at 4 to 5 months of age. And at 5 months of age, family introduced one of the commercially available early food introduction packets that has a lot of allergens. They mixed it into his formula. He drank it. And very soon afterward, he had an allergic reaction with hives all over and vomiting that needed to be treated in the emergency room. So that's when he came to us after that visit. And the IgE testing, and of course, we had to test for everything because the food allergen packet had a lot of allergens in it. And it showed positive sensitization to peanuts, tree nuts, soy, wheat, sesame, and egg. So now I kind of wanted to go through the early prevention efforts that have been ongoing. So for instance, despite primary prevention efforts, and we are still seeing food allergy develop. And this is very well showcased in Australia. And here they have the early nut study, which in which 9 out of 10 infants were consuming peanut before they were 12 months of age, and they used a similar cohort 2007 to 2011 to compare, and they found that only 3 in 10 infants were introducing peanut early. So they had a huge shift in early introduction of peanuts. And what was surprising is despite the efforts, the rate of peanut allergy did not go down. So even with early peanut introduction, where they were having such high success rates, the actual allergic children population was not decreasing. And then another study performed by Dr. Keat, she's currently at UNC. She was at Johns Hopkins before. She did a study with a total of 321 children who were between 4 to 11 months of age with no history of peanut ingestion and were considered to be high risk. So they had either moderate to severe eczema or another food allergy and a first-degree relative with peanut allergy. And they found that among the children with moderate to severe eczema, the rate of peanut allergy was 18%, even before they had ingested peanuts. So this is kids who'd never ingested peanut. They had testing done, and then this is food challenge confirmed peanut allergy. So what she actually found was that older age, so as you got older in age, and that's kind of broken down in these different lines, as well as severity of eczema was what strongly correlated with development of peanut allergy. So back to Alex. Over the next several months, Alex participated in many of the food challenges, especially the ones with lower IgE levels, and we were able to successfully introduce into his diet the following allergens. OFCs were not performed to peanut, walnut, cashew, hazelnut, and pistachio because they were very high IgEs. Baked egg, actually, we couldn't introduce. He did have a reaction on the food challenge day. So now that brings us to treatment because he is food allergic. Where do we go from here? So the first available food allergy therapy was, is Palforzia, and it was based on the New England Journal Medicine paper based on the Palisade study. And after a year of treatment, 50% of the individuals 4 to 17 years of age who had the equivalent of about a peanut a day in the form of the Palforzia product were able to consume 50% were able to consume the equivalent of 3 peanuts. So even though they were taking 1 peanut daily, they were able to ingest more in the setting of accidental exposure or in the setting of a food challenge. And then what I wanted to draw your attention to actually is that Palforzia was also tested in older individuals, but they found that in younger individuals, the effect was even more striking. And then they did it in 1 to 3 years of age, and now FDA has approved this product for younger age groups. The effect was even more striking. So essentially showing that the younger the child is when you're introducing oral immunotherapy, the better the outcomes are long term. And then a similar effect was seen in the IMPACT trial, which was a multi-center NIH-sponsored study with peanut oral immunotherapy, and Stanford was one of the sites. So was Johns Hopkins, and and Mount Sinai was as well. So in this study, they found that peanut oral immunotherapy was effective and safe in children 1 to 3 years of age. And as part of this study, they received the equivalent of about 6 peanuts daily for 2.5 years. And these are little kids. And at the end of the study, they found that 71% of the kids were able to eat more than double that amount. And then they had a 6-month avoidance period. So they tested sustained unresponsiveness by stopping OIT for 6 months. And 21% of the kiddos were able to maintain that level of desensitization, which was very impressive. Just 3 to 4 year olds. And this was done in 2017 and published by Vickery et al. And they wanted to look at the safety and effectiveness of OIT very early. And they essentially showed that as young as 9 months of age, it was essentially very safe and effective. And they compared another study, they compared infants with preschoolers. Again, they found the effectiveness was very high and safety was comparable. In fact, when they looked at the severity, they found that infants had lower severity of symptoms. So if it's even safer when you go younger. When we think of younger kids, we always worry about anaphylaxis because the babies can't tell us, they can't show us, they can't complain. So that we are also doing at our site the Sunbeam trial. I don't know if any of you have been part of that trial, but we're enrolling pregnant moms and then watching the babies up to 3 years of age and 5 years of age. And along the way, if we suspect food allergy, we're performing food challenges at 5 months of age, like very early. And we've been surprised at how safely they can actually be done because they react early in a very small dose and they tend to present with skin symptoms. So anaphylaxis in infants is something we worry about a lot, and especially with OIT in young children. But so far, the data has been promising and reassuring. Back to Alex. So Alex initiated peanut oral immunotherapy at 11 months of age with plans to initiate egg followed by cashew. And then his time to maintenance, because he's young, was prolonged because of viral illness, parent schedule, school break. So it actually took a surprisingly long time to do it. And along the way, he initially had some perioral hives, but over the course of it, he's done wonderfully. But given how long it's been taking him, when omalizumab was FDA approved in February 2024, treatment was discussed with the family. So this just kind of, as you all know, that Xolair got approved. And this is the paper that went through the data from stage 1 of the Outmatch trial. And I did want to share with everyone that the Outmatch trial is still ongoing. The publication and the FDA approval was really based on the first part of the study, but in the second part of the study, I think this is where things get even more interesting because it splits off into those who receive oral immunotherapy with only a short period of Xolair and those who just continue on omalizumab long term without any oral immunotherapy, or rather placebo oral immunotherapy. And then in stage 3, we stop omalizumab altogether and actually transition them to real world foods. So no longer kind of study provided powders, but foods they can buy off the shelf at the store. And there's also been a publication on this. So this is where we'll see how the combining omalizumab with food OIT is really going to impact safety compared to omalizumab by itself, the way it's FDA approved. But just to kind of walk through the OutMat study design, it was for ages 1 to 56 years of age. 177 patients were enrolled, and the study was done at 10 sites. And the first part of the study, that was what the FDA approval and the initial publication is based on, is 16 to 20 weeks. And the kids enrolled kids and adults, there were only 3 adults, so I tend to focus on the kids. But they have to have peanut plus 2 other food allergies to be able to participate. And the other food allergies had to be egg, milk, cashew, walnut, hazelnut, and wheat. And as part of the publication, what we saw is that after just 16 to 20 weeks of therapy, 67% of the kids receiving just Xolair or just omalizumab were able to ingest more than double the amount, the equivalent of 2 peanuts, even though they were reacting at less than a third of a peanut. So in just 4 months, they were able to ingest a lot more. And I don't know how everyone else's experience has been with cashew, but we always are, a little wary of cashew. We feel like the reactions tend to be a little more severe. They tend to react at lower doses. And as worried as we are with cashew, it also had the lowest efficacy rate on Xolair. But the other foods did fairly well as well. And just to kind of go into what this means, so 67%, yes, they could tolerate more than 600, but that's just the top dose. When you looked at the cumulative dose, that was 1,044 milligrams of cumulative protein. And 64% actually were able to ingest double that amount, so about 8 peanuts. And 57% were able to ingest the equivalent of a tablespoon of peanut butter. So really striking how much more they were able to ingest. And then in terms of safety, we of course had placebo and those on active omalizumab. We saw in the omalizumab participants, slightly more adverse events, and these tended to be more injection site reactions, hives, local hives, and serious adverse events in only 0.8% of participants. In the study, we did not see any episodes of anaphylaxis. And yes, there were dropouts throughout the study, but that was more when the oral immunotherapy was introduced and not during the injection phase. And even though, omalizumab just got FDA approved, there have been numerous studies over the years, starting as early as 2011, talking about omalizumab as an adjunct to food allergy and food or oral immunotherapy. And then real world implementation has been a challenge, and I'm sure many of you have dealt with this. Really, with our needle phobic patients, it's been really hard. Getting insurance approval has not been tricky. We've had patients who would benefit so much, but they were outside the dosing table for omalizumab, but where we have trouble getting it approved for them. And then really some of the questions that the families ask that we don't really know the answers to is, how long do we need to do this? Is this forever? And right now we don't have that answer yet. What do we do about our families and patients that have really high IgEs? Can we use it in combination with other therapies? And, will we be able to introduce real foods into the diet? Currently, with the FDA approval, it requires that they avoid the food, so it makes it very tricky to get coverage and approval while also introducing real foods. And then how do we, outside of food challenges, how can we predict response to omalizumab? It's fantastic that 67% do so well, but what about the patients who don't? Like, how do we identify those individuals and care for them? So those are all still standing questions and more research to be done. So back to Alex, because of his needle phobia, Alex had significant needle phobia. His family did not want to do Xolair, so they opted to continue OIT. And then after he reached maintenance for peanut, we were able to initiate, and he's currently undergoing OIT for egg. Um, and then over the visits, he's starting to experience dosing fatigue, and parents are struggling with daily dosing. And we're working with them on identifying different vehicles and strategies for daily dosing. But that is definitely a conversation. And that brings us to what else is out there? Like outside of OIT, outside of Xolair, what else could we be doing? So currently, peanut patch has been, underway. It's currently in additional phase 3 trials and being evaluated by the FDA for peanut allergy. So in this publication where patients had to put on a patch every day, they found that after a year of therapy, 67% actually met the primary endpoint. For instance, if they reacted to less than or equal to 10 milligrams of peanut protein at baseline, at the end of just putting on a patch every day, they were able to eat a full peanut. Or if they reacted at more than 10 milligrams, they were able to eat the equivalent of 3 peanuts. So that is promising approach. And then when I was talking about younger kids versus older, the same therapeutic option did not do as well when they looked at slightly older age group. It was still beneficial. It still helped. It's just when the kids were 1 to 3 years of age, it was the efficacy was more striking. And then another treatment option is sublingual immunotherapy. And Dr. Edwin Kim recently published this paper looking at peanut slit in children 1 to 4 years of age. And then in this study, they enrolled 50 peanut allergic children, and they were randomized to receive peanut slit versus placebo, and they received treatment for 3 years. And after that, they avoided all therapy for 3 months to assess the sustained unresponsiveness to see what the outcome was at the food challenges in the end. And what they found was that this was the median food challenge amount at baseline, and this was the median food challenge amount after daily sublingual for 3 years. So 60% of the population, that includes those who dropped out. So their data is, it looks like they failed. But if you just look at the patients who completed the study, almost 80% were able to tolerate a challenge of over 4 grams of peanut. And after 3 months of avoidance of the patients who completed the trial, 63% of the patients were able to retain that desensitization amount. And then even in this study, they further divided it into kids 1 to 2 years of age, 2 to 3, and 3 to 4. And they found that the younger the child, the better the outcome. And then in terms of safety, this slide deck is really to just show the majority of symptoms were just local or pharyngeal symptoms. And there were no instances of epi as part of the therapy. And overall, kids did really well. And then Sarah wanted me to talk about dupilumab as well, because this is something we use a lot in our eczema kids. And we've recently had studies looking at Dupi for food allergy, and the data wasn't as promising. And then for our patients with EOE who also have food allergy, but who may be on dupilumab, this is something we're always finding ourselves kind of exploring further into. But in a paper published in 2023, they looked at pediatric patients who were prescribed dupilumab for eczema, and after essentially 3 years, the IgE values dropped by over like between 80 to 100%. So there was a huge drop in the IgE values across all the different allergens that were tested. There is currently this publication that is should be out there already or is in press, published in Allergy, but this is looking at dupilumab in food allergy participants, and they were treated with dupilumab for about 24 weeks and done food challenges. And even though the food challenges were not that exciting, only 8.3% actually passed their food challenge. However, when they tracked the IgE values, those decreased significantly after just 36 weeks of therapy, which is about 9 months. So I'd be curious to see, as we get more and more data and better understand dupilumab in our food allergic patients, what this drop will mean over time in clinical reactivity. And then this is just a slide deck kind of showing the immune pathway of food allergy and all the different drugs that are currently being explored in this arena. And then, and one thing I just wanted to touch upon is, this idea of early life treatment and the immune plasticity. And like, why are the kids doing so much better on all the different forms of therapy? Why are they doing better when exposed early? And we believe it has more to do with the immune plasticity and how just malleable their immune system is at the early ages. And then the benefits, with every stage of this, you have to kind of go through the benefits and risks of treatment. And with early age, we are finding that there is increased adherence because the families are very much motivated. We are seeing lower risk of adverse events as well as the data. There's early improvement of quality of life. So the child isn't going through traumatic events or feeling excluded. They're already kind of involved. Potential for long-term remission, and just behavioral adaptability. However, when they're that young, we're always wondering, will they spontaneously outgrow their allergy? Like, are you putting them through therapy that they may not have needed? We worry about adverse events, of course, epi, and then treatment burden on a young child, the daily dosing and the dosing fatigue that we're seeing can be really burdensome. And then even though we think it's improving quality of life, we don't have a lot of data. So we do need to better understand that element and just cost effectiveness. If a child were to spontaneously outgrow their allergy, does this make sense to treat them for something that may not have happened, or may have resolved on its own? But through all of this, I think the highlight is that shared decision making is really important. Even though this figure is specific for OIT, it really applies to any form of treatment, and just talking through the risks, the benefits, what the goals are, what's feasible for the family and the clinic, and what the family's choices are. And that's it. Thank you so much. I'm going to stop share. And I'm happy to address any questions.
Thank you. Thank you very much for this very informative presentation. I actually have a question. I just wanted to know, for the Outmatch study, was EOE one of the exclusion criteria?
At baseline, yes, so for all of these food allergy treatment studies that are presented, EOE is always excluded. So if someone comes in with, a history of GI illness or a hint of EOE or symptoms that are concerning for EOE, they're not included in the trial at all. And in Outmatch, there have been cases of EOE that are being reviewed and will be in the next publication that's in the works right now.
So
And they
the
were once EOE is diagnosed, you're terminated from the study.
okay, so the EOE was observed during the study itself, not prior to.
Right,
Okay, I see.
exactly.
I see.
Yeah.
Okay, that's good
So
to know.
yeah, yeah,
Thank you so much. I do want to
no
open it to
problem.
our audience here. Any questions? Please feel free
I
to
have a
unmute.
question.
Yes.
Yeah.
Hi, I'm Allie. I'm a food challenge nurse at Mount Sinai.
Hi.
Um, hi, okay, so the Dupixent decreasing the IgE level was really interesting, and I was just wondering, I know in our clinic, once a patient starts Xolair, we don't even check the IgE usually because we know it, makes it inaccurate. But if the decrease in IgE from Dupixent is not thought yet to have clinical significance in terms of passing a food challenge, do you still interpret those IgEs the same way once a patient starts Dupixent?
That is such a great question. And I think it is actually some of our we are trying to better understand that. And the only way, unfortunately, right now is to do the food challenges to see does it actually correlate. So when let's say we do this in our EOE clinic where they started Dupixent, they want, we repeated labs and the IgEs are dropping and the families are like, what does this mean? I mean, I usually tell them, we don't know yet what it means. And the only way to know is to do a food challenge. So we're trying to, and which is probably really hard at your institution as well, just getting
Yeah.
like those challenges scheduled. But we are trying to get, we're not, we're hesitant to give guidance without food challenge confirmed data in terms of what does that mean for them?
But you would still offer a food challenge if you saw a decreasing IgE after Dupixent, even though we're not sure yet that that's relevant.
We would. Yeah, we are trying to, especially if they have a pretty non-risky history. For instance, their EOE is well controlled. I'm not worried about flaring that. They're followed up closely. They haven't had any recent reactions to the food in question in like the past couple years. So they have to meet kind of the low risk category. But yeah, yeah,
Okay, thank you.
great question. Thanks, Allie.
I'm sorry. I'm going to stop recording so people don't have to feel shy in asking questions. So,